Okay, so this is obviously the Module B Orthopaedics Rheumatology tutorial. I'm going to start with orthopedics, and then we've got more rheum conditions later on in the tutorial. I think there's a checklist of what we're going to cover in the orthopedics part. We've got some SBAs and some kind of like just one question like quizzes on each slide as we go, and then some more basic UCL style SBAs as well. So this is the stuff we're going to cover. We've got the principles of fracture management as a whole, and then we've got some more specific fractures that you need to know of. So how they're caused, their signs, symptoms, and also how we manage them as well. And that's neck of femur fractures, scaphoid, and ankle fractures. And then with fractures, obviously we can damage nerves. We talk about some of the nerves we can get damaged in different fractures, and the limping child. So obviously we do peds in year 5, but you can and you are expected to know some common presentations in adolescents and older children as well. Cauda, equina, and metabolic bone disease as well as the orthopedic stuff. And then we've got another one of these slides later on with what we're going to do in the rheum slides. So let's get started. We've got, so as I said, we're starting off with the principles of fracture management. So just in general, how we go about dealing with fractures. Say if we're in an A&E department, somebody comes in with a suspected fracture, how we deal with them and what we do. And they're the 4 R's. So the first R is resuscitate. That's the first thing we do with any patient coming into A&E. So you'll use your Dr. A, B, C, D, E approach. Make sure the patient is stable enough for you to continue to then look closer at the injured limbs or whatever other injuries they have. But for this case, we're obviously going to presume they've got a fracture somewhere. So step 2 would be to reduce the fracture if it's displaced. This is quite a common SBA question. So things UCL like to ask is if somebody comes straight into A&E, they will say, what is your first, what would you like to do first? And be like assess airway or something like that. With a fracture, they say like, do you want to go to surgery or put a plaster cast on, or do you want to reduce the fracture, etc. So the next thing we do is we reduce the fracture if it's displaced, and that's because we want to keep the neurovascular function of obviously everything that's either at the fracture and then obviously further on from the fracture as well, because if it's compromised, everything below the fracture will also be compromised as well. So we do that really early on, just to make sure there's no, to reduce the chance of any longer lasting damage from that fracture. Step 3, retain the position. So now we've reduced it. We want it to stay in that position until we can find a permanent solution to let it heal. So we can put it in a temporary cast, and then we want to take them to surgery to get it a more permanent solution. And that is external fixation, where you get a big cage built around like the outside of a leg, for example, is one of the common ones you might have seen. And internal fixation using screws, plates, nails and stuff, and their surgical procedures. So then the bone can heal in place, and we reduce the chance of any longer lasting effects. And then obviously rehabilitate. We can't just send them off and then expect them to be completely functional again. We need to help them with physio, and that will include occupational therapists, etc. So a question here, how long does it take an upper versus a lower limb fracture to heal? Let's give a few seconds. If anyone wants to answer, then go ahead. And if not, I'll just go forwards. So upper limb 6 weeks, lower limb 12 weeks is the general rule. Obviously, there's some variation in that, but the general rule is upper limb will be 6 weeks to heal, lower limb will be a 12-week healing process. So one of the first specific fractures we're going to talk about are hip fractures, or you might see them as neck of femur fractures as well. And there are 2 types. We have extracapsular and intracapsular. So the capsule is split on the diagram here by the pink line. Anything to the right of the pink line is intracapsular. Anything to the left of the pink line is extracapsular. And the 2 types of extracapsular, they determine the management that we do. So an intertrochanteric fracture would be a dynamic hip screw, and a subtrochanteric is an intramedullary nail. And these managements are just things they need to commit to memory, really. because they can come up in SBAs, and it is probably one of the more common questions that you can get asked in the ortho module in an SBA, along with the Garden classification, which we're going to talk about later on as well. And that is for intracapsular fractures. So we've got non-displaced 1 and 2 Garden classification, and then in 3 and 4 of the Garden classification are displaced, and we deal with them differently. So Garden 1 and 2 are both non-displaced, but Garden 1 is if there's an incomplete fracture, and then Garden 2 if the fracture is complete. So you'll see it on the side, and that's going to come to next what I mean by that. So I'll explain it more then. But for Garden 1 and 2, we go for a open reduction internal fixation, and that's with screws or a DHS again. And then when we get to displaced, which is 3 and 4, so they are, I'll explain it on the next slide what it means. So 3 and 4, it's displaced fracture, and we go for a total hip replacement if they're young, so less than 60, or it says well elderly. So if they can be elderly, but if it says in the question they garden frequently, or they frequently like to go to the shops and they're walking quite a bit, then we can give them a total hip replacement. But otherwise, we go for a hemi-arthroplasty. So that's just like half of a hip replacement, really. You've got the hemi part, and it only replaces the femoral head. So that's if they're, it will say, so the comorbidity part could be like an older person with a dementia or something, a common one is in a question, or they're just not very independent or mobile themselves. And one thing to note is if they are very young, so around 35 or less, we go for screws. And the reason for that is a total hip replacement or the hemiarthroplasty, they can only last for around 10 and sometimes 15-ish years. So obviously you can imagine if you're only 35, you're 30 or something, getting one of these, you're going to have to get them replaced many times through your life. Whereas the screws last much, much longer, and sometimes don't even need, most of the time don't need to be replaced. So they can stay in and they don't need to be changed at any point during their life, which is obviously a big advantage. And obviously when I've been talking about that, the intracapsular fractures seem like there's more of a kind of invasive, intense management, I guess. And that's because there's a greater risk of avascular necrosis of the femoral head with an intracapsular fracture. So they can damage the blood supply just because of the position of the fracture. And again, we'll talk about that with the after the Garden classification, the next few slides.
I guess so if we're adding something, so if you draw a horizontal line from the bottom of that pink line, then anything below that is subtrochanteric. Anything from that diagonal pink line up to that horizontal line would be intertrochanteric. Anything from the middle of the neck would be transcervical. I think anything from the very bottom of the head would be subcapital, which are both types of intracapsular. And I think that's probably as much as you need to know.
Yeah, exactly. Thanks. So some SBA buzzwords for these hip fractures. So buzzwords are kind of, one thing to say about them is it's very easy to just see it and then click an answer, but it's still very important to read the rest of the question, obviously, and make sure you're not missing anything. It could just be there to throw you off. But typically buzzwords that you'll see with a hip fracture, shortened, abducted, and externally rotated leg is what you'd see. But then we know what a shortened, adducted, and an internally rotated leg would indicate.
Is it a posterior dislocation?
Yeah, exactly. Good. So posterior dislocation of the hip is what comes with the shortened, adducted, internally rotated leg. Good. And it could be the most common one you might already know of is if somebody's in a car crash and they have their knees on the dashboard. People sit like that. I presume it's more comfortable because it is quite a common thing. People sit like that, and that's one of the common ways that a posterior hip dislocation happens, because obviously the force is then pushing your hip backwards past the joint. Good. So when I was talking about the avascular necrosis, this is kind of the reasoning behind the avascular necrosis. So the femoral head is a mainly retrograde blood supply, and it's from the deep, so the profunda femoral artery. And then if you do have a displaced intracapsular fracture, you can damage that supply, and then it can lead to the avascular necrosis. So that's why you want to get in there and sort it out to preserve the femoral head, because obviously we don't want a dying femoral head. We don't want to miss anything. So it's important to do an X-ray and really look. I've got some tips, including like Shenton's line and things later on, something to look at, just to make sure you're really not missing these fractures, because obviously this is a big effect that can happen. And also, if it's a displaced fracture, you need that realigned in surgery, because it will just heal wrong and then it'll be quite bad in terms of functionality. So you want to get it sorted out and get it fixed, and that's obviously the hemiarthroplasty or the total hip replacement for the 3 and 4 Garden classifications. Other causes that you should know about for the avascular necrosis: thrombosis. Obviously, if you have a clot in the artery, then you're not going to get any blood going to the further branches, and then that's what goes to the femoral head. Long-term steroid use. So that could be a question. It could be, I don't know, somebody who has arthritis, long-term steroid use, and they come in with like hip pain or something, and that's something you can consider, and alcohol abuse as well. So I said I was going to talk about what the Garden classification is. I said 1 and 2 are both non-displaced, 3 and 4 are both displaced fractures. And what I meant when I said incompletes and completes, so you can see in here, type 1. First off, the femoral head is in the position that it should be in, but then we can see the fractures going through the neck of the femur here. So we've got, in type 1, you can see the fracture goes halfway through the bone, it doesn't go all the way through. And then for type 2, you can see the fracture line goes all the way through from one side of the bone to the other side of the bone. And that is what we mean by complete fracture. It's going all the way through. And then type 3, we can see in the bottom left, and then obviously type 4. And you can see straight away that the femoral heads are not in the position that they should be in. They've moved down on the femur. And that is the displacement that I was talking about. And they're both complete fractures. It's type 3 is a partial displacement. So you can see it's moved a lot less than the type 4. So fully displaced is type 4. You can see there's a much more drastic move across the fracture line, and it's much more further out position than the type 3. So the difference between 3 and 4 are the amount of displacement that we're seeing, and the difference between 1 and 2 are whether the fracture is complete or incomplete, and then that determines the treatment options, which we talked about a few slides ago. So as we said again in the previous slide, the highest risk of avascular necrosis is 3 and 4, and that's because of the displacement of the femoral head. Okay, so we've got an SBA here. 57-year-old woman falls from her horse and complains of right hip pain. She was previously fit and well with no medical issues, and this is her hip X-ray. What is the most appropriate management for this lady?
Is it the nail? Because it's subtrochanteric.
Yeah, good. So so the answer is nail. So yeah, it's a subtrochanteric fracture, which we said was one of the extracapsular fractures. Good. And then obviously it said right-sided here. This is the right side of the patient. So one thing I wanted to talk about was Shenton's line. I don't think it's not drawn on any of these, but Shenton's line, I can't really point out, but if you is there a way to get a pointer on here? I don't think so. Anyway, so it might be easier if you just Google Shenton's line, but this is the most common thing and probably the best way to look at a hip fracture, to see if it's especially an intracapsular fracture, because if Shenton's line is disrupted, then that is pretty indicative of a neck of femur fracture. But obviously there's your other things such as symmetry between both sides. And then obviously on this one, we can see so Shenton's line is probably not really affected in this because it's an extracapsular fracture, so it's therefore important to have your process to go through to look at X-rays as well. But yeah, definitely Google Shenton's line just to have a look at it, so you can see this in kind of the inside curvature of the femur and then into the hip joint as well, and that could be indicative of neck of femur fracture. But again, yeah, your process is really important. But good, you spotted it was an extracapsular fracture. And then an intramedullary nail is what we said is for a subtrochanteric fracture of the hip. Good. So a scaphoid fracture. Scaphoid bone is just in your wrist down here, and it forms the floor of the anatomical snuff box. And just like the hip, this bone is also at risk of avascular necrosis. It's got the retrograde blood supply, which we talked about before, and this is from the radial artery this time. The most common mechanism of injury is a fouche, or a fallen and outstretched hand. So there are some other fractures that are also that's the most common mechanism of injury. So it's also important to be able to distinguish between the two. Don't just recognize fouche and then press scaphoid fracture, for example, in a question. But it is the most common in this case. And there are different types. So this is the scaphoid bone. We've got the proximal pole, the waist, and the distal tubercle. The waist is the most common, but obviously it can happen at the distal tubercle and the proximal pole as well. And the signs of a scaphoid fracture, we're going to have pain and tenderness over the anatomical snuff box here. Obviously, you can imagine if there's a fracture there, it's going to be painful where it is. Joint effusion and pain on ulnar deviation and thumb compression. So they're two things, especially the ulnar deviation. SBA might say pain over the anatomical snuff box and pain on ulnar deviation, for example. And that should get you thinking about a scaphoid fracture. They can be difficult to diagnose because they don't always show up straight away in an X-ray. And we do 3 views of an X-ray. That's AP, lateral, and scaphoid views. I don't think they're on here, but again, if you Google it, it'll probably be the best way for you, rather than me describing it, best way for you to see it. Just so it makes sense in your head why we're looking at different places. And because it doesn't show up straight away, we want to repeat it after 2 weeks in a fracture clinic. So someone comes to A&E, they're falling out on their hand, but you can't see anything on the X-rays. You've done the different views, you can't see anything. You want to book them in 2 weeks for a fracture clinic, where they can be assessed again. And the definitive test is an MRI, so we can see it much better on the fracture. So we do that if we still think a scaphoid fracture is pretty likely, but we aren't seeing anything on the X-rays, and we kind of pretty sure that it could be a scaphoid fracture. So here, it's kind of hard to see if you're not zoomed in, but that's an example of a scaphoid fracture in an X-ray. So again, if that could have been in a fracture clinic 2 weeks after the incident, or it could have been in the A&E. So it is important, if you don't see it in the first instance, to book them back in 2 weeks. And that's because of the avascular necrosis. You don't want to leave a fracture there if there's risk of the blood supply being affected and the bone being necrosed. So the management, it says here, treat if there's clinical suspicion, and that's because, again, of the ambiguity with the X-rays. If it's a visible, undisplaced fracture, cast for 6 to 8 weeks using a splint or a elbow back slab. I'm just going to go back to the start because this was on one of the slides. Briefly at the bottom. Yeah. So this one here is the back slab on the left. And this one is a complete plaster. So that's just the differences between the two. If you haven't seen them before. Where is my slide? Here we go. A displaced scaphoid waist fracture or proximal pole fracture. It's displaced, so we want to go in there and we want to do a surgical screw fixation. And then it's not fractured, but there's snuff box pain. You want to 2 weeks of a cast. So when we're waiting the 2 weeks between the first presentation and the second X-ray, we want to put a cast on their arm. So maybe splint their arm or something for just in the meantime, so they don't re-injure themselves more if it is a scaphoid fracture.
I guess another thing to mention might be, so fouche can also result, a common one you see in exam questions, college fracture, which is a transverse fracture of the radius, which causes a dinner fork type deformity. That's what you often see. And the reverse version of that would be, and that is dorsal displacement. So the reverse version of that which has a garden spade, which is kind of a reversed dinner fork deformity, is the Smith fracture, which has volar angulation rather than dorsal, which is also a fracture of the radius.
Yeah. Okay, so Ankle fractures is one of the other specific fractures that you could get asked about and you should know about. So the commonest fracture of the lower limb, and the usual mechanism of injury is a low energy rotational force. So if you're walking down the street and you roll your ankle off a curb, something like that. And there's different. There's a classification system, and they point to different managements. So we've got obviously the normal one on the top left. The top right is a Weber A, and that's a below the joint line, so the syndesmosis. It's hard to point out, but the syndesmosis is the where the tibia and the fibula join, and the whole joint comes together. So below that joint line, and it's a very stable fracture because the syndesmosis is still intact. So we call that a stable fracture. And then we've got Weber B, which is at the joint line I was talking about. And that can be stable, it can be unstable. So there's some uncertainty there. But again, you'll use that clinical judgment and you look at the x-ray, see how severe it is to know that, and also examination. C is above the joint line, and that can damage the syndesmosis itself. So this is a unstable fracture because obviously if the syndesmosis and the ligaments around the joint are damaged, then there's going to be some instability there. So and then that's the same again with B. So B can also present with some ligament damage, which then makes that gives the instability of the joint. So obviously we find out an X-ray find out about a fracture with an X-ray, and the Ottawa rules are what we use to establish whether a patient needs an X-ray or not. So the 3 points: inability to weight bear for 4 steps, tenderness over the lateral malleolus or tenderness over the medial malleolus, and is usually inability to weight bear for 4 steps. Obviously around the time of injury. So if they say, "Oh, I couldn't walk afterwards," or if they get to A&E and they really can't put any pressure and walk on their affected foot, then you're thinking, and obviously they can have tenderness over the lateral and medial malleoli as well, and that's when I'm thinking you want to X-ray the ankle. So again, it's just saying here that you want to reduce the fractures as soon as possible to keep the neurovascular supply intact to the lower foot. And then, so when I talked about the different classes, I'll tell you about the management as well. So for Weber A, you want to either put them in a boot, or you want to put them in a below the knee plaster cast. And then if it's a non-displaced Weber B or C, we want to go for just a straight below the knee cast. And then if it's a displaced fracture, as we said before, we're going to probably have to go in there and surgically sort it. So we do a closed reduction for a displaced fracture. And so the reason, obviously, we go for even in the non-displaced with B or C to the below the knee cast is because there's some instability there. So we need the extra support around the joint because the ligaments could have been damaged in the syndesmosis. Okay, so we've got some emergency situations now in orthopedics. The first one being compartment syndrome, and it's limb and life threatening if it's not treated. So compartment syndrome, so there's pressure in a muscle compartment, and that exceeds the perfusion pressure. So then that means there's going to be ischemia of the nerves and muscles, and it can lead to necrosis. And the most common fractures is seen in as a supracondylar fracture and a tibial shaft fractures. And so we're in the first term still. So you guys won't have vascular week, sorry, is in vascular is in mod B. So you might have learned about this, the symptoms of like what's it called, acute limb ischemia. So they all start with P. So we've got them here as well in compartment syndrome. So pain is really extreme. It's out of proportion to the injury. So you look at it and you're like, it shouldn't be as painful as the patient is saying. So that should raise your attention to maybe it could be compartment syndrome. And if they had a fracture as well, then it should raise suspicions. A pulse it could be weak or absent, and that's because of the as I said, the compartment pressure in the muscle. The pressure in the muscle compartment, is exceeding the perfusion pressure. So then the blood is struggling to get past that point. It's going to be pink, so warm, erythematosus, or swollen, and then the other P's. So paresthesia, pallor, paralysis, perishingly cold are the late signs, and that's when you start to get really, really reduced blood supply. And so then you can't get the redness anymore because the blood supply is really low. So it's a clinical diagnosis because it's really serious. We don't want to mess around with loads of diagnostic tests. If it's you see these, so the P's, the features, and they've just had a tibial fracture, for example, tibial shaft fracture, you're thinking of this. And then the treatment is if they have a dressing or a plaster cast on, for example, you want to get that off straight away. So if this comes up in a question, you would say if it says if they have a cast on, your first port of call would be to if get help is there, you always say get help, but it will be to loosen the dressings or remove the plaster cast, for example, because you need to reduce the pressure in that area. And then after we've done that, they need to go to surgery for an emergency fasciotomy, and that's to decompress the area. And so the golden hours, I should say, is obviously early as possible, but up to when we get to the 4 to 6 area mark is when muscle death starts to occur, and that's when it gets to the irreversible stage of damage. So we really don't want to avoid that. We do want to avoid that, obviously. And then rehydration, because there's a risk of AKI due to the myoglobinuria, and that's because of the breakdown of the muscles due to the ischemia and the possible necrosis that's been going on. So we've got some nerve injuries to talk about as well, and these are in the question. It will probably give you a mechanism of action and then the symptoms as well. So that's in the table. So axillary nerve, humeral head fracture or shoulder dislocation, and some of the symptoms we'll expect to see are deltoid wasting because axillary nerve supplies a deltoid, and then for the same reasons, so unable to abduct the shoulder past 30 degrees, and then the regimental badge area would have numbness. And so usually the patient can abduct to around 30 degrees area because the supraspinatus initiates the abduction movement. So, but past there is mainly the deltoid muscle. Radial nerve is a humeral shaft fracture, and it's classically known as Saturday night palsy. And some of the symptoms, you get a wrist drop and you lose sensation at the base of the thumb. The reason it's called Saturday night palsy, I think there's a picture here. Yeah, so this is the symptoms. So the Saturday night palsy is supposedly a drunk person falls asleep on a chair and their arm is resting over the chair, and that compresses the radial nerve, so they present with them symptoms. And then median nerve. So a big one is carpal tunnel syndrome and a supracondylar fracture as well, but the main one here is carpal tunnel syndrome. We have thenar wasting and hand of benediction. So hand of benediction is this, what we're seeing here. So this patient is being asked to make a fist, but their first 3 fingers stay in the same place, but the little finger and the ring finger both move in the fist direction that you'd expect. And then the ulnar nerve is a cubital tunnel syndrome, is the most common thing that you could see in a question, or compression at the elbow. And the symptom here, so wasting of some of the other muscles it supplies, and the ulnar claw. And the way to remember it is, it says here, the ulnar has an R in it, and then you're looking at the resting position. So they look pretty similar. Do the median hand of benediction and the ulnar claw, but it's just what you're asking the patient to do. If you're asking them to rest and you're seeing that, it's likely an ulnar problem. And if it's while they're making a fist and you're seeing that, it's likely the median nerve that's causing the issue. Okay, so we mentioned carpal tunnel syndrome and the median nerve, and now we're going to talk about carpal tunnel syndrome itself. So it's trapping of the median nerve in the carpal tunnel, and the carpal tunnel is underneath the flexor retinaculum, and it's usually due to inflammation, because inflammation then forms edema, and then edema can increase the pressure in the area, causing the compression. The retinaculum is like a fibrous band that's like kind of here on your hand, and it then goes over the carpal bones. And inside there you have the median nerve itself, and you also have other tendons. You have 4 tendons of the flexor digitorum superficialis, 4 of the flexor digitorum profundus, and then also the flexor pollicis longus as well, the tendons of that. So causes, very nicely form the anagram median trap. So mixed edema, which is in hypothyroidism. I won't read them all out, but you can see them there. Way to remember it very nicely, median trap. And if you just remember, it's quite nice to remember the actual anagram itself, and obviously remembering what it stands for is harder. So if you just keep recapping this, commit it to memory, then if you see a pregnant lady, for example, with these simple symptoms, you can go, oh, I know the P from median trap is pregnancy, therefore it can cause carpal tunnel syndrome. So features, tingling over the lateral 3.5 fingers. It's worse at night, thenar eminence wasting, and weakness of thumb abduction. And we have tests that you'll perform when you're performing your the hand and wrist exam. And this is Tinels or Phelan. So the Tinels test is where you tap on the wrist around here, and that if it recreates the symptoms, then it's positive. And Phelan's, so we have them place our hands like this, so a hyperflexion of the wrist, and we do that for like a minute as well. And if it recreates the symptoms or worsens the patient's symptoms, then that's also a positive test. And I think, oh yeah, so they're the two tests. So electrophysiological studies are the mainstay of diagnosis, but it's also can be clinical as well. If these things are positive and you're having the other features above, and you have one of the main causes, so a risk factor, then it could be clinical diagnosis that you have compartment syndrome. So some management, we always start with conservative with most things that aren't emergency problems. And that's wrist splinting at night. So it holds your hand in like an extended position, so that keeps it out of the flexion. Because obviously, if Phelan is a hyperflexion, that makes it worse. Therefore, if your wrists flex normally, then that's going to make it worse as well. So if you keep it in extension, then the symptoms are relieved. And then if that doesn't work, we go to medical corticosteroid injections into the area. And then if that doesn't work again, surgical decompression. So we can go in and we can cut the flexor retinaculum to relieve the pressure in the area. And that is the third line and most definitive way of sorting out the problem. We've got shoulder pathologies. Rotator cuff injury. So when you're performing your exam, if you've learned this for a shoulder exam, this will make sense. If not, you will learn it and then it will make sense. So painful arc is pain on shoulder abduction. And it can be like in between, at the middle of the arc. So at the start it's fine, and then it goes out, pain, and then it's fine again. It gets near the top. That's where the painful arc is. An empty can sign. So you hold your hand upside down, apply some slight pressure to the patient, and try and resist your pressure. And some lateral shoulder pain as well. Feature in the history: elderly, trauma, or history of overuse. Treatments: physio and NSAIDs, which is most muscular problems in ortho, steroid injections, and then surgery if you've completely torn the muscle during that high impact exercise, for example. And then frozen shoulder, also known as adhesive capsulitis, reduced range of motion. You have 3 phases of it: freezing, frozen, and thawing, which is improving. So it's freezing, and then it gets frozen, which you can't move, and thawing obviously is kind of like a defrosting process in terms of like if you're like thawing food, for example. And then so it starts to get better, and it lasts around 18 months, but then usually they most of the time they have completely recovered and they have no long lasting effects. So in an SBA, the most common one that's always highlighted in bold is diabetes. So you might say a 45-year-old woman with diabetes rotates with this problem, blah blah blah, and then the most likely thing is a frozen shoulder or history of a cuff tear, because if they have if they tear the muscle, there's then going to be inflammation, scarring, that stuff that can cause frozen shoulder as well. So treatment, you can reassure them it's self-limiting, but then they usually do need some physio and NSAIDs as well, or we can then give them steroid injections, which can also have an effect. Yeah, and then there should be a question. Yeah, so the question here: which movement is most affected in patients with adhesive capsulitis? If anyone knows. Move on. Okay, so external rotation is the most common movement affected, or the movement that is affected the most in adhesive capsulitis. Okay, so nerve injuries of the lower limb. We have sciatic nerve, first of all. So this is most commonly injured in a posterior fracture or dislocation of the hip, and also a hip replacement as well. So in the surgery, it can damage the hip because of the proximity of the nerve. Symptoms, if it says foot drop and widespread sensory loss below the knee. The most distinctive sign that we see is a pain that radiates all the way from the lower back down to down the back of the legs, or maybe around the side of the legs as well. It can be like a dull pain, or it can be kind of a sharp stabbing pain in your leg as well. And yeah, so they're the most common causes of injury. A femoral nerve injury is an anterior fracture or dislocation of the hip, and we are likely to see weak hip adduction and weak knee extension because the femoral nerve innervates the quadricep muscles. The common peroneal nerve, knee trauma, high boots, or a knee replacement, says winds around the head of the fibula, easily damaged, and that's the reason of the mechanism of injuries. So you get weak dorsiflexion and eversion, foot drop, and a high stepping gait. So the high stepping gait is because you're aware of the foot drop, so you're trying to avoid dragging your feet along the floor, and so you slap your feet down because you're not fully aware of where your foot is in regards to the floor. And also, if you're aware of the foot drop, you're subconsciously going to want to avoid scraping your foot across the floor because then you can fall over. There's also sensory loss over the dorsal aspect of the foot and lateral aspect of the calf. And you can see we've got widespread sensory loss on the back of the leg with the dorsal of the foot with the sciatic nerve and the common peroneal nerve. And that's because the common peroneal nerve is a branch of the sciatic nerve. So that's why we have some overlap with the symptoms. So I said we're going to talk about the diseases in children. I don't think in our exams we had many of these. I'd probably save it for our year in 5th year, but you do need to be aware of them because they can ask you where, because it's an ortho condition. So you do need to still be aware of it. So developmental dysplasia of the hip is a congenital deformity, and it's where the femoral head can be completely or partially displaced from the pelvic acetabulum. So the joint is just not exactly where it needs to be. And we usually identify it in neonates by a screening test, which are the Ortolani and Barlow's tests. And the keywords or the buzzwords you could see, which are because the causes, so bilateral or breech babies, and the breech babies is where the baby comes out feet first. Birth disease, 4 to 8 years is the most common age to get it. Progressive hip pain, and then if we do an X-ray, which I think there is one yet, so we can see joint space widening, and also a small femoral head. And then SUFI, so they can, so obviously they're going to present with pain, both of these, but SUFI is more, so slipped upper femoral epiphysis is usually in 10 to 15-year-olds or obese males. And it can refer the pain to the knee, and there's a limited internal rotation that we see, and that could again be another buzzword for in an SBA. So when we are looking at an X-ray, I think there is one of SUFI. There are some lines we can draw called Klein's lines, and that's across. You can't see my cursor, but you can imagine the superior border of the femoral neck. If we draw a line across that border, then the femoral head will be completely below that line in SUFI. So if you just, again, if you Google it, it will be a lot easier for you to understand if you've seen it. So I'd recommend Googling what the Klein lines are, and then in a normal versus a SUFI X-ray. And if a patient presents knee pain, what other limb do you want to examine? So we talked about that. We're looking at hips, so it's the hip. And hip pathology can present as knee pain because like Q angles and stuff. So if there's a problem with the hip, therefore the whole anatomy of the lower leg is probably going to be changed, and that can affect the knee joint as well. So another emergency, Cauda equina syndrome. So this is where we get compression of the lumbar and sacral nerve roots. and that makes up the Cauda equina, and it's most commonly caused by a large disc herniation. So the features, and these again, if you see these in a question, it's probably Cauda equina. There's not really many other things that cause these. So lower back pain, obviously, is a generic one. But then we get bilateral sciatica, urinary incontinence, saddle paresthesia, decreased anal tone, and we can feel that on a PR exam. So saddle paresthesia is like they can't, their perineum is numb, or when they're wiping after going to the toilet, they can't feel it. And incontinence is obviously they can't hold wee in. Investigations, PR spine, lower limb exam. That's what we do when someone comes straight to A&E, but we need an urgent whole spine MRI. So in a SBA, the answer will probably be urgent whole spine MRI if it's asking for the first investigation you want to do. Treatment, straight to neurosurgery for urgent surgical decompression. And if it's caused by malignancy, we give IV dexamethasone, and that was a question in our exams this year. So if it's caused by malignancy, then we give IV dexamethasone. So that's just a fact you need to kind of commit to memory because they can ask it, and they did for us. So it's important to remember. Metabolic bone disease, we can have one, osteoporosis. So osteoporosis is reduced bone mineral density, and then because of that, we increase the risk of fracture. One thing, however, that's important is the bone profile is normal. So the calcium, the phosphate, and the ALP will all be normal in osteoporosis. And these are the risk factors. So shattered, again, you can think of a fracture as shattering the bones. I won't read them all out, but so smoking, steroids, hyperparathyroidism, alcohol, etc. All risk factors. And so you want to risk assess all women over 65, men over 75, and younger if we suspect that they're getting fragility fractures or fracturing really easily, because there must be a reason behind that, and that could be osteoporosis. So there's 2 scoring systems we do. So a FRAX is we get low, medium, and high. So low we give lifestyle advice to, and that could be such as quit smoking, low alcohol, make sure you get enough calcium, vitamin D, so you can give supplementation, things like that. And then medium, we'd send them for a DEXA scan, we'll talk about in a minute. And then if it's a high 10-year fracture risk, we give them immediate bone protection, so bisphosphonates. So a DEXA scan, they go if they're age over 50 with a fragility fracture or major risk factors for osteoporosis. So the T score, and this is based, you're kind of compared against the bone mass of a young reference population. So if it's a 90-year-old woman, you're still going to be compared against younger women. So the bone mass of younger women. If we have a score between -1 to -2.5, we call that osteopenic, and then if they're less than -2.5, so they're osteoporotic and they have osteoporosis. And a Z score is adjusted for age, gender, and ethnicity. So I have seen quite a lot of questions asking what the difference in T and Z is. So T is the young reference population, Z score adjusted for age, gender, and ethnicity. So how do we manage them? So all patients at risk should have vitamin D and calcium supplements. It could be something really sly in a question, which points towards needing vitamin D supplementation. It could be like they're unable to leave the house or something like that, so then they're not getting enough sunlight, and that's when they need vitamin D supplementation. So medical, they get it if they are less than 2.5, or the woman is over 75 with a fragility fracture, and we give them bisphosphonates first line. So oral alendronate is first line, and IV alendronate is second line, and we always give them with PPIs, and that's because of the side effects of bisphosphonates. They can cause like ulceration and stuff of the stomach lining and reflux. So you want to avoid that by giving PPIs. And then if that doesn't work, we go to denosumab, which is a rank ligand inhibitor. And I think the rank ligand plays a part in like osteoclast activation and activity. Therefore, if we inhibit it, there's going to be less osteoclast activity, and osteoclasts are what they resorb bone. So if we stop that, there's going to be less bone resorption, and therefore, in theory, a higher bone mass, bone density. And then we consider hormonal replacement therapy if appropriate, such as like menopause, menopause women, etc. So Paget's is where we have increased bone turnover, not just osteoclast activity. We have excess osteoblast activity as well, but formation usually exceeds resorption. So therefore, we have increased bone mass, but it makes weaker bone. So therefore, although it looks like there's more bone, it's weaker, so that increases the fracture risk, and we also get some deformity as well. Risk factors. In a question, it would usually be an old man, but there's a family history link as well. But in a question, it usually will be an older male. Most commonly affected bones, and they're in order: spine, skull, pelvis, femur, and then long bones of the lower extremities. And features, so if it's an older man coming with deep, boring bone pain, and then some deformity and enlargement, because the deformation exceeds resorption. And then it could also be like they've had a fragility fracture, for example. So investigations, they have an isolated raised ALP. So in any question, if the other bone profiling stuff is normal, so calcium phosphate normal with an isolated raised ALP, that should raise suspicions of Paget's with, again, the symptoms and features that they're presenting with. And management, analgesia, vitamin D supplementation, and again, we give bisphosphonates. So there's some complications to be aware of Paget's. So we've got deafness because of the impact of the excess bone on the skull and things. So we can trap cranial nerve 8 because of the excess bone formation that causes deafness, and that can be, again, a presenting feature in a question. So bone sarcoma, fractures because of the decreased density, the decreased quality of the bone. And so on an X-ray, we'll see thickened skull if it's a skull fracture, thickened bone, and also some sclerotic areas. And if there was a biopsy taken, the kind of buzzwords to be aware of is a mosaic pattern of lamellar bone. That's what you'd see on biopsy. And then it says high output heart failure. And I'm not too sure of the mechanism. I'm not sure if you two are aware, but I think it's linked to like a decreased peripheral vascular resistance you get. I'm not sure why that happens, but you do. And then the heart needs to pump more and work more in order to kind of meet the body's demands for the vascular resistance being low. And so that's it for my part. I'll stop sharing my screen so someone else can share theirs.
Okay, can everyone hear me? I'm just going to be sharing my screen now, and I'm going to be doing the rheumatology part of this.
Have I stopped? I think I've stopped sharing mine.
Yeah.
Okay.
Okay, can everyone see this?
Yeah.
Can they see this? Okay, fine. Okay, so yes, I'm going to be doing the rheumatology part, the first part, and then Sidharth is going to be doing the second part. So I'm going to be covering red hot swollen joints, degenerative joint disease, arthritis, which is basically just the different kinds of like arthritis, vasculitides as well. Okay, so we're going to be starting with a very, very commonly asked SBA question, the red hot swollen joint. So what are 3 differentials for any red hot swollen joint? So basically, the most common kind of differential, or the thing we need to rule out first, would be septic arthritis, which is an emergency. Then we have gout, and then we have pseudo gout as well, which can kind of present similarly too. Okay. So as I said before, septic arthritis is a medical emergency. And this is basically an infection of the synovial joint, and this can kind of destroy the whole joint capsule within 24 hours. And this is something we should always rule out when a patient presents with a red hot swollen joint. So in terms of kind of the presentation, as I said, the description kind of speaks for itself. However, the patient will probably have a systemic kind of fever, raised ESR, white cell count, and CRP. So basically the classical findings of an infection. They cannot wait there. They'll be in a lot of pain and they would even be limping as well. So the different investigations to consider would be a joint aspirate. So this is a very essential investigation for any red hot swollen joint. And this is very important, is done before antibiotics, because if you do give antibiotics and then you aspirate the joint, it could kill some of the kind of like pathology or organisms causing the arthritis and kind of mess up our results. You will need to send that aspirate for MCNS formally to get kind of like a histological diagnosis. However, you can probably tell it is an infective joint if the aspirate is grey or turbid. Okay, so as another kind of reminder as well, never aspirate a replaced joint. So joints that have undergone joint replacement, they will need to be kind of given a lavage formally in the theatre. Okay, so the common causative organisms are Staph aureus, which is the most common, Neisseria gonorrhea. So this is the most common if you're kind of looking at like a young patient, sexually active adults, and we'll always, the staple of the treatment is IV antibiotics, following the local guidelines, of course, which varies between different trusts. However, normally and in question banks, it does say flucloxacillin for 2 weeks intravenously, and clindamycin, of course, if the patient is allergic to penicillin. And then if cultures return another organism that is sensitive to other antibiotics, of course, we can change this around. And then after our 2 weeks of intravenous antibiotics, we would like to start all antibiotics for 4 to 6 weeks. And this is quite a hefty regimen, as I said, and this is just because this is a medical emergency. Okay, and then, as I said, if this does continue, we'll need to take it to theatre for a full lavage. And this is the first point of call if someone does have a joint replacement in that joint that is red and swollen. Okay, so crystal arthropathies. So there's kind of two types, gout and pseudogout, and it has a similar presentation to septic arthritis as well. So in terms of gout, I'm going to be kind of comparing the differences. So gout is caused by accumulation of monosodium urate crystals, and it's most commonly in the metatarsal phalangeal joint, so commonly said the big toe. Risk factors are poor renal function, diuretics, high alcohol, red meat intake, Leese-Nyon syndrome, but also just diets full of kind of uric acid as well. Investigations would be to aspirate, because this is how we can differentiate between gout and pseudogout. And in terms of the aspiration fluid, we'll get negatively birefringent needle-shaped crystals. And when I go on to pseudogout, you'll see there is a difference. In terms of the X-ray, they're not very commonly X-rayed, but you'll see joint effusions and punched out lesions, which are commonly kind of compared to rat bite lesions. The management is for acute presentations, which are extremely painful, we'll use NSAIDs, such as colchicine, and a PPI, of course, because we need to use gastroprotection whenever we prescribe an NSAID. And if the patient has a low EGFR, we need to kind of confirm this before we give colchicine too. Okay, and then in terms of prevention of attacks, we'll give allopurinol. So in contrast, pseudogout is calcium phosphate crystals, which are deposited in the joints. And this occurs commonly in large joints, such as the knees and the wrists. And the risk factors of this are hemochromatosis, acromegaly, and hyperparathyroidism. And in terms of hyperparathyroidism, it's pretty self-explanatory because we get a kind of increase in calcium in the blood due to that. In terms of investigations, aspirate the joint, and we get weakly positive birefringent rhomboid-shaped crystals, in contrast to the needle-shaped crystals in gout. In the X-rays, we get chondrocalcinosis, which is basically just a snazzy term of calcium deposition in the cartilage and the articular cartilage. Managements are NSAIDs and steroid injections. Okay, and just moving on to kind of what they look like under the microscope in terms of aspiration. We can see here, we get kind of our needle-shaped crystals, and in here, we get our rhomboid-shaped crystals. In terms of gout, as you can kind of see, punched out lesions, which look like rat bites. As you can see, there's some overhanging edges going on here. And in pseudogout, we can see some chondrocalcinosis in the other radiograph. Okay, so I'm going to be moving on to the first kind of SBA question of rheumatology. So a 52-year-old male presents, patient requires treatment for an acute gout flare. His past medical history includes hypercholesterolemia, type 2 diabetes mellitus, and stage 3 chronic kidney disease. Which of the following is the most appropriate initial management strategy? So we're just going to be going through that. Okay, I'm just going to move straight to the answer actually. So the actual answer is colchicine. Now, we might kind of want to say naproxen out of instinct just because it's an NSAID. However, if we're kind of looking closely into the question stem, he has stage 3 kidney disease. And in terms of naproxen, we should avoid NSAIDs like that. So colchicine would be our next best treatment option. And acutely as well, as he's just presented, he would be needing the acute management plan, which is colchicine, not allopurinol. Okay, I'm going to be moving on to osteoarthritis now. So osteoarthritis is not an inflammatory condition, unlike rheumatoid arthritis. So patients typically will present with morning stiffness, but this is less than 30 minutes. So the time period is very important because in rheumatoid arthritis, our morning stiffness typically will last longer than 30 minutes. Osteoarthritis is worse with exertion, particularly at the end of the day, and the patient will usually feel kind of a gradual onset and some pain and crepitus associated with that too. Patients will typically be quite old as well. So osteoarthritis is associated with Heberdin's nodes, which take kind of
Zahra, I think you're muted.
Okay, so wait, I was muted through that whole time. Should I start again?
No, I could hear you.
It was just that slide. It was just that one slide.
Oh, okay, fine. Let me go back to the screen. Okay, can you see the slides now?
Yeah.
Okay, did it just mute the osteoarthritis bit?
I think it was just the management maybe, because we heard the Heberdin's nodes and stuff.
Oh, okay, that is so weird. Okay, we'll just continue. Okay, so yeah, so Heberdin's nodes and Bouchard's nodes are two kind of common presentations. In an OSCE as well, when you're kind of doing the hand examination, be sure to name and make an effort to look for these, as they really like that. I'm not sure how common they are, but they really like you to spend a lot of effort kind of feeling the DIP and PIP joints. In terms of the x-rays, there are quite classic signs, and these can kind of be condensed into kind of loss. So loss of joint space, osteophyte formation, subchondral sclerosis, and subchondral cysts. So loss of joint space is pretty self-explanatory. Osteophyte formations are these little kind of erosions that kind of protrude at the edges of the quite obvious in x-rays. Subchondral sclerosis and also subchondral cysts, which are kind of little pockets of like inflammation that are present in the cartilaginous area of the joint. Okay, so primary is the most common form of osteoarthritis, but you can get secondary osteoarthritis too, and this is probably secondary to joint damaging diseases such as hemochromatosis, which is iron deposition, previous trauma in the joints, which cause that localized effect. So normally kind of overuse in a particular joint too. So in terms of the management of osteoarthritis, Pretty conservative for the first part. So lifestyle changes, weight loss, physio, muscle strengthening exercises. However, if the pain is unbearable and conservative management isn't working, we'll kind of give paracetamol, topical NSAIDs, capsaicin cream, first line, and also intra-articular steroid injections. But this is normally after we've tried oral analgesics. And then the definitive treatment, of course, is a joint replacement. I'm sure you've heard of kind of hip replacements for osteoarthritis of the hip joints too. Okay, so second SBA. A 38-year-old woman is being investigated for swelling and pain in the MCP joints of both hands. She has also been experiencing fatigue and unintentionally lost around 2 kilograms in weight over the past 2 months. She has no rash and neurological and cardiovascular examinations are normal. Initial bloods performed by her GP reveal a raised CRP, positive rheumatoid factor. So which of the following investigation results are most keeping with her presentation? Okay, so going to move on to the answers now. Okay, so positive anti-CCP antibodies, which are very commonly raised in rheumatoid arthritis, and we can kind of see from the stem that her MCP joints are the most troublesome in her presentation, and these are commonly affected in patients with rheumatoid arthritis. I'm going to be moving on and explaining a bit more about rheumatoid arthritis now, actually. So rheumatoid arthritis is an inflammatory arthritis, unlike osteoarthritis, which is caused by more kind of wear and repair and overuse. So rheumatoid arthritis is an inflammatory condition, and in inflammatory conditions it's normally systemic, so we get symmetrical small joint involvement, namely mostly the hands and the feet, in the MCP joints as well. So we get morning stiffness, however this lasts over 30 minutes in comparison to OA, which is normally less than 30 minutes. It gets better, surprisingly, with activity. And as I said, systemic symptoms, because we want to think about that inflammatory picture. So it spares the DIPs, mostly targets the PIPs and MCPs, and also the carpal joints. So we get kind of 2 characteristic kind of deformities, the boutonniere deformity and the swan neck deformity. We also want to look out in our OSCEs for any nodules, and nodules can also be present on the elbows, so make an effort to kind of expose the patient up to the elbows, have a feel of the elbows, see if there's any rheumatoid nodules there. We want to have a look as well to see the general kind of formation of the hand joints, see if there's any deviation, any subluxation, or any abject kind of deformities of the joints, such as the PIP and MCP joints. In terms of antibodies, so rheumatoid arthritis is associated with certain kind of antibodies present in the blood, namely rheumatoid factor, which is positive in 70% of patients. So it is sensitive. However, it can be raised in other inflammatory conditions. However, anti-CCP or anti-cyclic citrullinated peptides are very sensitive, and they're also very specific. So if a patient does have anti-CCP in their blood, it is very likely that they do have rheumatoid arthritis. We can also use certain scoring systems when taking a history from a patient, such as the DAS-28, and this kind of tells us how many joints are affected and kind of links that to the prognosis of the patient. In terms of extra-articular features, so outside of the joint symptoms, we get some lung symptoms such as lower lobe fibrosis and effusions, nodules, as I already mentioned, eyes, so uveitis, heart pericarditis, IHD, and Felty syndrome, which is kind of rheumatoid arthritis, splenomegaly, and neutropenia. So that kind of comes under quite a rare syndrome, but it is part of kind of covering rheumatoid arthritis too. In terms of management, conservative measurements such as physiotherapy and analgesia. However, patients do normally require kind of medical management. So if the patient does have flares, or if they're kind of acutely unwell, we'll normally give steroids. However, if we're wanting to kind of maintain their therapy, we'd give DMARDs first line, and we'd start that immediately as soon as the patient is going to start showing symptoms. And we normally bridge this using prednisolone. And the most common DMARD you're going to hear about a lot is methotrexate, which is an antifolate agent. However, it's very important to be aware of the side effects of methotrexate, and it is an antifolate, so we need to give folic acid alongside methotrexate. And it's very important that a patient adheres to their dosage regimen and their folic acid regimen, just because the side effects are so severe. And the most dangerous one is myelosuppression, because this is kind of blunting the body's immune system, and it can leave a patient very vulnerable to infections. We can also give hydroxychloroquine. However, this is normally something we would give for systemic lupus. And then biologics. So if a patient has refractory, and that's basically rheumatoid arthritis that is not responding to our first-line therapies, we're going to be giving anti-TNF alpha therapies such as infliximab, which are monoclonal antibodies. Okay, so radiological features. So in terms of X-rays, we're going to be seeing subluxations, we're going to be seeing ulnar deviation, loss of joint space, erosions, and periarticular osteopenia, which is basically kind of weakening of the bone integrity around the joints affected. And very characteristic X-ray, as you can see, there is clear ulnar deviation and also marked deformity too. And soft tissue swelling as well. Okay. So Sjogren syndrome. So this is an autoimmune syndrome, and it kind of attacks a lot of exocrine glands. So exocrine glands are glands that kind of secrete saliva, tears, and this causes dry mucosal surfaces. It is 9 times more common in women. It is associated with rheumatoid arthritis and systemic lupus, and also non-Hodgkin's lymphoma. It can be primary or secondary, and other features. So we can get gland dysfunction, gland swelling, dry eyes, dry mouth, dry skin. So kind of any mucosal surface that would need lubrication. Because of this, we can get dysphagia, dry cough, vaginal dryness, arthritis, bilateral parotid swelling. There are investigations that we do. However, the Schirmer's test, they do like you to mention that. However, it's not very commonly done. It involves putting filter paper just near the tear ducts, the lacrimal glands, to see how many tears collect. And this is normally very uncomfortable for patients, so they normally steer away from this. Another thing is a salivary or parotid gland biopsy too. In terms of the antibodies associated, rheumatoid factor, anti-nuclear ANA antibodies, anti-Rho and anti-SSA, and anti-LA and anti-SSB. So there's quite a large repertoire of antibodies associated with this syndrome in particular. In terms of management is normally quite conservative. We would give kind of artificial tears or pilocarpine to stimulate the muscarinic production of tears. We'd like to replace saliva, frequent drinks, chewing gum, and if the patient does develop arthritis because of this, normally NSAIDs will manage the pain and inflammation. Going to be moving on to SLE or systemic lupus, which is a very, very key thing in terms of rheumatology, and they ask a lot of questions about this in your OSCEs and also your SBAs. So it is an autoimmune condition. It is a systemic inflammatory condition as well, and it just is a lot of autoantigens flying around the bloodstream and associated with the deposition of immune complexes in organs. So the stereotypical patient would be a young female Afro-Caribbean patient who reports feeling very fatigued, perhaps losing weight, and getting kind of arthritic symptoms in the hands and feet. So in terms of presentation, this is a very wide variety of presentations, and it's typically relapsing and remitting trajectory. So normally the systemic or acute flare-ups would be fever, fatigue, and weight loss, symmetrical non-deforming arthritis in the hands, knees, and feet, rashes, so butterfly rash, which will go over kind of the malar folds of the face, a discoid rash, which is kind of more raised on the skin, and also vasculitic skin changes and palpable purpura. So there are normally 3 types of organs that are affected. So we'd get glomerulonephritides, clots, so predisposed to kind of thrombotic episodes, periendocarditis. So this is basically immune system attacking the myometrium of the heart. And this is an example of the butterfly rash, which is sparing the nasolabial fold. So very characteristic rash that just goes over the face and the cheeks and the nose bridge. And systemic lupus is associated with antiphospholipid syndrome, which is a syndrome of procoagulation. So recurrent VTEs, livido reticularis, which is another kind of skin sign, obstetrics, so recurrent miscarriages, and thrombocytopenia. So this is an example of livido reticularis, commonly kind of seen on the thighs. You can also get drug-induced lupus, which is quite rare, but is associated with kind of antihistone-associated antibodies. So there's certain drugs here that can cause drug-induced lupus as well. So in terms of serology and management, so 99% positive ANA antibodies, rheumatoid factor 20% positive, and anti-Smith, anti-dsDNA, anti-Rho, and anti-LA. So anti-Smith is the most specific. Anti-dsDNA is also very specific as well. So if a patient has those in their bloods, quite likely that they do have SLE. And drug-induced lupus presents with a different antibody, being the antihistone antibodies. Other tests, so kind of CRP, characteristically normal. If there is a coexistent infection, CRP may be raised. However, a raised ESR and a normal CRP is characteristic of SLE. There's normally low complement levels as well, C3 and C4, and this is due to kind of the complement being activated and used up by kind of immune deposition. In terms of general management, we'd want to be giving hydroxychloroquine and NSAIDs. Mycophenolate can also be used, but this is for severe and refractory cases. And for the skin and the rashes, we'd give sun cream, topical steroids for flare-ups. Now, for hydroxychloroquine, there is a side effect to be aware of, and that is kind of induced retinopathy. So that is another very severe side effect, and patients should undergo eye checks for that as well. I'm going to be moving on to scleroderma, which is kind of in the name. It's a skin kind of, the presentation involves the skin quite a lot, and it's a systemic condition. So as I said before, it causes quite a lot of kind of feverish symptoms and affects a lot of the organ systems in the body. So you can get limited cutaneous scleroderma, which is called Crest syndrome, which is skin fibrosis involving the face and the hands below the elbows and the feet. Antibodies associated with this are anti-centromere antibodies, so characteristic calcinosis, Raynaud's syndrome, esophageal dysmotility, sclerodactyly, and telangiectasias, which are basically just veins kind of forming on the skin. You can get diffuse cutaneous scleroderma as well, which is skin fibrosis, which can involve the whole body, contractures, and this is typically a poor prognosis because it kind of invades other organ systems. Antibodies associated with this are anti-SCL70 and the anti-RNA polymerase. The general presentation, dysphagia, because obviously esophageal dysmotility associated with crest, skin tightening, so kind of roughened, tight, shiny skin, and microstomia, which is kind of a small mouth. Complications. So complications of scleroderma are quite severe. So the most common mortality or cause of mortality is interstitial lung disease presented with pulmonary hypertension, because of renal artery kind of fibrosis, GI bleeding, and poor wound healing. So to pick up scleroderma, we would do a serology to detect autoantibodies, and would also use monitoring of these as well. Management, so we treat the complications, normally suppress the immune system as a systemic problem, which will slow the progression, and it's important to kind of manage this early, most importantly with immune suppression such as mycophenolate mofetil and iloprost infusions. So this is just examples of a typical presentation. You can see some calcinosis, which is calcium deposits under the skin. We'd get microstomia, which is a small mouth, and the typical skin tightening, the shiny skin, as you can see in this picture. Okay, so moving on to polymyositis and dermatomyositis. So this is an insidious onset of progressive muscle weakness and tenderness. So patients may get dysphagia, dysphonia, and respiratory muscle weakness as well. As I said, because it can kind of target any muscle, including the diaphragm muscles we need to breathe. It is important that this is often a paraneoplastic phenomenon, so you'd also need to screen for cancer in a patient presenting with the characteristic symptoms. Dermatomyositis is myositis, so the typical muscle pain and weakness. However, it has kind of skin problems associated with it as well. So macular rash, so the shawl sign over the back and the shoulders. Heliotrope rash, often on the eyelids, associated with edema, so that can be seen as a puffiness under the skin. Nail fold erythema, Gottron's papules, which can also be picked up in an OSCE examination. So we'd like to examine hands for papules associated with dermatomyositis. Here are some pictures of what I've just explained. Investigations, so predominantly raised muscle enzymes, so a raised CK is characteristic, and this is because of the muscle weakness and the muscle tenderness. And EMG shows characteristic fibrillation, and the muscle biopsy is very important to determine the diagnosis. In terms of serology, anti-MI2 and anti-Jo1 associations with this as well. Management is immunosuppression, namely steroids and prednisolone. Hydroxychloroquine will manage the skin changes. Okay, moving on to seronegative arthropathies. So seronegative means that not really associated with any antibodies that can be picked up. So no rheumatoid factor, may be associated with HLE types. So HLE-B27 is quite a commonly associated one. Asymmetrical large joint or oligo or monoarthritis, so affecting few or perhaps one joint. And the most common one that is asked about is ankylosing spondylitis. We can also get enteropathic arthritis, but this is normally associated with kind of Crohn's disease, celiac disease, Whipple's disease, and is associated with kind of the bowel problems, and gets better once we start treating the causative problem. Also reactive arthritis as well. Psoriatic arthritis can present quite similarly to reactive arthritis as well, but is associated with kind of psoriasis and the characteristic skin plaques. So starting with ankylosing spondylitis, typically seen in young men presenting with lower back pain and stiffness, which gets better with exercise. Signs are reduced lateral flexion, forward flexion, HLA-B27 associated, But HLA-B27 can also be associated with reactive psoriatic arthritis and also ulcerative colitis. Other features of ankylosing spondylitis to be aware of are the 6A's, so apical fibrosis of the lungs, anterior uveitis, aortic regurgitation, Achilles tendonitis, AV node block, and amyloidosis. Treatment of ankylosing spondylitis will normally be NSAIDs and exercise. However, if patient fails onto NSAIDs, the next kind of mode of action is an anti-TNF alpha, such as infliximab. Quite important to be aware of the radiological presentation. So you can see there's a bamboo spine here, which is quite a late presentation, and vertebral lumbar squaring as well, which are quite late as well. So psoriatic arthritis is.
Sorry, do you want me to take over?
Oh wait, yeah, sure.
Yeah.
Sure.
It's fine. It's fine. How do I take control from you? Oh, fine. Right.
Okay, there.
You can see that, right?
I can't see the slides.
You can't.
Yeah, I can't see the slides.
Okay. What about now?
Yeah, I can see it.
Okay. Just give me a sec. Yeah, I mean, Zahra covered most of this. So scleroderma complications. Yeah, I think she mentioned most of it. I think there was something.
I think we were on reactive arthritis or psoriatic arthritis.
Yeah, I was gonna mention something. Oh yeah, so for diffuse cutaneous, it can affect any part of the body and the visceral organs. So it can become more severe. So lung, heart, renal involvement, as she mentioned, interstitial lung disease is very common. Most common cause of death is respiratory involvement. So for things like hypertension, you would start hypertensive treatment like ACE inhibitors. You'd get pericarditis, esophageal dysmotility, things like that. Calcinosis, calcium deposits, telangiectasia, spine, skin tightening we mentioned. She covered most of this as well. Things to add might be, I've got a good mnemonic, to be fair. I'll share it on the chat. It's clay, so let me copy and paste this. It's basically this. So dermatomyositis and polymyositis turn your muscles into clay. And those are the some of the 5 investigations that you do, which are all elevated in the condition. Muscle biopsy would be the definitive diagnosis, as it says. Do you cover management for this prednisolone? Yeah, first line is corticosteroids, second line either DMOD, like a methotrexate or hydroxy. You'd specifically do hydroxychloroquine in dermatomyositis rather than the polymyositis because it's more effective for skin changes. One thing to mention for this is, so myositis causes bilateral proximal muscle weakness, so towards the trunk. So pain is either absent or mild, as opposed to polymyalgia rheumatica, which is another condition often associated with giant cell arthritis. I don't know if it mentions it later, but I'll mention it now. And often SBA questions will ask you to differentiate between the two. So in PMR, you'd see pain and stiffness, but no muscle weakness, as opposed to in this, you would see bilateral muscle weakness. The things on the right, it's prominent in dermatomyositis. Okay, that covers most of it. Yeah, she mentioned most of this. So for ankylosing spondylitis, so clinical examination, reduce lateral flexion, reduce forward flexion. When you do a spine exam, you see this thing called Schober's test, and which is the distance before and after flexion. Like you draw two lines, and if that line increases by, I think, 5 centimeters when the patient bends forward, I think that's the diagnostic test. That's actually the test for reduced forward flexion. You'd see reduced chest expansion as well. There are other ways, it's not just those ways. Like atlantoaxial instability, aortic regurg, actually it already says that here. Amyloidosis often leads to glomerulonephritis. There's peripheral arthritis, more common in females. Okay, this is say the investigations for this. You do an X-ray. First, plain X-ray of the sacroiliac joints is the most definitive investigation for this. As you can see, these signs, squaring of the lumbar vertebrae, squaring of the lumbar vertebrae, fusion of the vertebral bodies in the bamboo spine. Second line would be MRI. You can also do spirometry, which is common in this because you'd get reduced chest expansion. So the spirometry would show a restrictive defect if you want to link that into RESP. You'd get well-formed syndesmophytes in the X-rays. And that's not in the images, so I can't really show you that right now. Management, stop smoking, NSAIDs exercise as it says there. Physiotherapy, you encourage swimming. That's a common thing. Okay, psoriatic. So psoriatic arthritis. Let me just pull it all up, to be honest. I'll give you guys a mnemonic for psoriatic arthritis. So the mnemonic I have is drama. And it shows you the different types. So distal interphalangeal psoriatic, rheumatoid-like, asymmetrical oligoarticular, arthritis mutilans, and ankylosing spondylitis-like. So, okay, I'll go through it from the beginning. So this is a symmetric polyarthritis. It's very similar to rheumatoid arthritis. It's actually 30 to 40% of cases, so it's the most common type, which is the symmetrical polyarthritis. And then the asymmetrical one, which as you can see in the drama mnemonic, that's the second most common. And that typically affects the hands and the feet, the asymmetric oligoarthritis. The spondylitic pattern, which is the ankylosing spondylitis-like pattern. Often you get it with sacroiliitis. That's third most common. Then you get distal interphalangeal joint disease. I think the pencil and cup deformity, that's what you see on the top right is an example of DIP. And for some reason, I always see it in exam questions. Arthritis mutilans is a severe deformity of the fingers and hands. You see these telescoping fingers. You can Google that. It's very obvious. And of course, you also get the psoriatic skin lesions, the plaques. You get periarticular disease. You get tendonitis, tenosynovitis, basically lots of inflammation in the tendons and the ligaments, and you get dactylitis. Nail changes is it's a common one for this. So you can get pitting, which is and yellowing ridges on onycholysis, which you can see at the bottom right. Investigation is usually X-ray management by, you refer to the rheumatologist, obviously, but it's very similar treatment to rheumatoid arthritis. But first line, you start with conventional DMARDs like methotrexate. Then second line, you change to biologic DMARDs. So that's the anti-TNF agents. And third line, of course, you start with NSAIDs at the beginning, but then third line, you do targeted synthetic DMARDs, which is these immunobiologics like tofacitinib and stuff like that. You can add in monoclonal antibodies. It has a better prognosis than rheumatoid arthritis. In X-rays of patients with psoriatic arthropathy, usually distal interphalangeal joints are predominantly affected rather than the metacarpal phalangeals and proximal interphalangeals, which are more common with the rheumatoid arthritis. Okay, and that covers most of it. So can everybody, everybody who watches this recording back, and everybody watching it now, can you guys just scan this QR code on your phone and give us all some feedback? We would really appreciate it. It would be helpful for us. I'll show this QR code again at the end, but please do. Zahra, can you just scan this and check it's the right QR code? Pretty sure it is. And I'll move on. So yeah,
it's the right code.
Okay, cool. So this is something I mentioned earlier, actually. If anybody wants to shout out, go ahead. But weakness, unilateral headache, low-grade fever, pain when moving from sitting to standing, but no true weakness. Kind of mentioned it earlier, but you need some extra information. Okay, I'll move on. So prednisolone, because this is polymyalgia rheumatica, which is often accompanied by giant cell arthritis, which is why you do a visual field assessment, and this condition responds very well to high-dose steroids. Yeah, so you get prednisolone or methylprednisolone if there's visual field abnormalities. And it's actually emergency referral. So if you're a GP, you call the ambulance, send them to hospital straight away. So start soon as possible. And it's, like I said, it's prominent because it's shown by the no true weakness. So vasculitides. Yeah, so there's a variety of vasculitides, vasculitises. It's divided into large vessel, medium, and small. Yeah, general features, systemically unwell, systemic symptoms, basically, fever, myalgia, night sweats, weight loss, quite similar to cancers. So it's a common differential, actually. Large vessel can be broken down into temporal arthritis, Takayasu arthritis, medium vessel polyarthritis, nodosa, Kawasaki, small vessel, Wegener's, Churg-Strauss, microscopic, and then the immune complex ones like Hinox, Conline, Peripheral, Goodpasture syndrome. Yeah, so small skin vessels, purpura. You can see the purpura at the bottom right. So yeah, it's associated with a wide range of vasculitic conditions. Blood supply to nerves can be affected, which can lead to mononeuritis. Glomerulonephritis is another thing that you see often with this. There's a massive overlap between some of these, like HSP and glomerulonephritis, like IgA nephropathy, for example. Yeah, it can affect the blood supply, causing ischemia of the affected organ. which is as you can, which is a thing in GCA. That's why it's an emergency. So you want to prevent blindness. That's why it's an emergency. So this I've already mentioned quite a bit. Large vessel vasculitis, which overlaps with PMR. You can see it's inflammations of large vessels, commonly the temporal artery. That's why it's also known as temporal arteritis. A temporal headache, visual changes, headache on either side, general fatigue. You often see a raised DSR. It's like what patients often describe as a throbbing headache with pain on chewing and a tender scalp. Typically, the patient is older, over 60 or so. It's usually rapid onset. Jaw claudication, as I mentioned. It's often there's often an overlap with amaurosis fugax, which, if you know, is a type of stroke. Is it a TIA or a stroke? It's a type of stroke, let's say. You can check that in your own time. Which would, so you can get amaurosis fugax. You can also get blurring, diplopia. So you have to do a visual field exam. It's a secondary to anterior ischemic optic neuropathy. When you get ophthal, you'll learn the different types. 50% also have features of PMR, like aching, morning stiffness, and proximal limb muscles, no weakness. Investigations raised DSR, CRP may be elevated. You do a temporal artery biopsy, which you have to repeat, and you don't rely on it. It just aids you because there's skip lesions. So, which means some of the parts of the biopsy, so some elements of the artery may not be affected. So, if you biopsy a normal part, it's not a representative of the condition. See a creatine kinase EMG usually normal. You do fundoscopy, you can see swollen, enlarged optic disc, blood margins. I mentioned the high-dose glucocorticoids, ASAP, prednisolone if there's no visual loss, IV methylprednisolone if there's evolving visual loss, which would usually be initiated under urgent ophthalmology review. So you same-day review. It's an irreversible visual damage if it happens. Along with the prednisolone, you would consider bisphosphonates for bone protection because it's quite a long-term course, long tapering course of steroids that you need. Okay. Yeah, I've mentioned that. Next, we move on to type-chaos, which is another large vessel vasculitis. And yeah, you get inflammation and occlusion of the aorta, get absent limb pulses. It's more common in younger females, 10 to 20, 20 to 40, 10 to 40 or 20 to 40, depending where you look. Stenosis, thrombosis, aneurysms. You get systemic features of vasculitis as well, of course, followed by intermittent limb claudication. You can see that by an absent limb pulse. More common in Asian women. You can get a carotid bruit if you do an examination, weak peripheral pulses. You get upper and lower limb claudication usually on exertion. You get hypertension. Aortic regurg is common. So you get an aortic regurgitation in about 20%. It's associated with renal artery stenosis, which is a common exam question. The picture shows the aorta, of course, and it's not showing the renal artery, but you can see multiple stenoses in the branches of the aorta. Management, prednisolone, low dose aspirin, and bisphosphonates again. You consider immunosuppressants if that's not working. It's case dependent, and you can consider neurosurgery, endovascular surgery, to break up the occlusions. Okay, moving on to polyarthritis nodosa, which is a medium vessel vasculitis, which means it affects medium-sized arteries, so it doesn't involve capillaries or arterioles or whatever. So this is necrotizing inflammation can cause aneurysms. This is more common in middle-aged men, usually around by middle-aged I mean about 40 to 60. It's often associated with hepatitis B infection. You get a palpable purpuric rash, which you can see on the right. That's a common picture. Yes, again, you get the constitutional symptoms, and usually more than one organ system, which raises the likelihood of a vasculitis. A diagnosis is combination of things, but by examination, history, laboratory tests, possibly a biopsy, can affect the kidney, which can cause renal failure. It can affect the coronary system, leading to ischemic heart disease, MI. Can affect the gastrointestinal tract, leading to abdominal pain, nausea, MSK, arthritis, myalgia, obviously. Central nervous system, you can get skin and eye complaints, skin you've already seen. The management, I'll get onto Kawasaki in a second. Fine. Is there anything else I should mention? You can often see livedo reticularis, which you can Google. It's often associated with polyarthritis nodosa, renal. You've obviously all the different things like renal failure. Complications can be an aneurysm formation, which can cause an hemorrhage. Okay, moving on to Kawasaki. So that's this medium vessel vasculitis. You see it more commonly in children. It can cause serious complications like coronary artery aneurysms. So this is a high-grade fever, which lasts for more than 5 days, characteristically. Conjunctival injection, bright red cracked lips. I've got a mnemonic for this, actually. I'll share it with you guys. It's crash and burn, it's called. You can check the chat. Yeah, so conjunctivitis, rash, unilateral adenopathy, strawberry tongue, hands and feet, which is red, swollen, flaky skin, fever for greater than or equal to 5 days. Management is high-dose aspirin. It's one of the few times you give aspirin in children. Otherwise, there's a risk of Rey syndrome, which causes liver and brain damage in children. You can also give IV immunoglobulins, and you do a echocardiogram as well, which you use to test for coronary artery aneurysms. Then Berger disease, also known as thromboangiitis obliterans. So this is strongly associated with smoking. I always remember this as ESR as the features. So E being extremity ischemia, S being superficial thrombophlebitis, which is thrombus formations in a superficial vein, and then you get the Raynaud's phenomenon. Extremity ischemia meaning intermittent claudication and ischemic ulcers. So this is a mixed vessel vasculitis. It's a type 3 hypersensitivity, I think. That's the classic triad. So genital ulcers, oral ulcers, and anterior uveitis. It's more common in Eastern Mediterranean countries like Turkey, as you can see on the map. More common in men, younger adults. It usually affects. I think it's HLA-B5 as the associated genetic link. There's usually 30% of patients have a positive family history. You can get the other symptoms of arthritis, obviously. You can get erythematosus as well. There's no definitive diagnosis. It's a clinical diagnosis. Management is to treat the symptoms, and then immunosuppressive treatments like steroids, azathioprine, methotrexate, biologics. Yeah, colchicine, cephalosporin. Okay, so moving on to small vessel. Okay, I'll cover each of these in turn. I'll do microscopic after Churg straws. So Churg straws, there's a good Venn diagram on plasmid, but these are all small to medium vessel vasculitis. I would consider Churg straw syndrome. The common thing you see is asthma, eosinophilia, which is obviously allergy as a strong link to asthma. You get mononeuritis, and it's P-ANCA positive. in about the majority, let's say 60%. Then you get Wegener's, which is granulomatosis with polyangiitis. Again, small, medium, which affects the respiratory tract. So the upper respiratory tract symptoms you'd see are epistaxis, nasal crusting, sinusitis. Lower respiratory tract, you'd get dyspnea, shortness of breath, hemoptysis. And you'd also get a rapidly progressive glomerulonephritis in most patients. You can get both P and C ANCA in this, but it's tends more to be C ANCA. You get a saddle-shaped nose deformity, that's common. You can do a chest X-ray for this. It's a wide variety of presentations, as you can tell. Standard management, steroids, plasmapheresis, DMARDs, plasma exchange. Microscopic is a small vessel ANCA vasculitis. It's mixed. You can get both P ANCA and C ANCA, but P ANCA is slightly more common. You can get fever, renal impairment, a rash. Again, it's kind of a mix of the features of the two conditions below. So you can get the respiratory tract symptoms like shortness of breath, hemoptysis, and you can get the mononeuritis multiplex like the Sjogren's and the glomerulonephritis. Okay. Last couple of diseases. So antiglomerular basement membrane disease, also known as Goodpasture's. It's a small vessel vasculitis. Usually you see pulmonary hemorrhage and rapidly progressive glomerulonephritis. It's caused by anti-GBM antibodies against collagen. It's more common in men. I think it has a bimodal age distribution, so you can see it in about 20 to 30 years, as well as 60 to 70 years. Features are, like I said, pulmonary hemorrhage and rapidly progressive glomerulonephritis, which you'd see manifest as a rapid onset AKI, proteinuria, hematuria. You do a renal biopsy, you can see linear IgG deposits. Management would be plasmapheresis, steroids, cyclophosphamide. You get the pattern. These are the general management for most vasculitis conditions. If there's end-stage renal failure, which can happen in this, you do a renal transplantation. The risk factors that increase the likelihood of pulmonary hemorrhage would be things like smoking, pulmonary edema, low respiratory tract infection, and then Enoch's condyline and purpura, which has an overlap with IgA nephropathy. It most commonly affects children. It's about 3 to 5 years old following a viral upper URTI, which your features would be a purpuric rash, abdominal pain, polyarthritis. You'd see hematuria, proteinuria, nephritic or nephrotic syndrome. In young children, you can see intussusception, which is telescoping of the bowels, so you can Google it. It's often a clinical diagnosis, but you can do investigations like it's a raised ESR, CRP, IgA. You can do urinalysis to check for protein or blood in the urine. You can monitor blood pressure because, of course, you can get hypertension. I think the gold standard for diagnosis in this is skin and renal biopsy with immunofluorescence for IgA and C3 complement. Management in this is actually, in most cases, do resolve spontaneously. So it's spotted management. You can give NSAIDs for arthralgia. You control blood pressure with antihypertensives. After an episode, you monitor with regular urine dipsticks for 12 months to check for renal impairment, to check for blood in the urine or protein in the urine. If there is renal involvement, you would start corticosteroids and consider plasmapheresis in severe cases. Good prognosis. Okay, moving on. Yeah, hematuria, hemoptysis, respiratory tract, Goodpasture's, remember that. Okay, so exam SBA. Give you guys a second and then moving on. So yeah, subchondral cysts. You probably know the loss mnemonic for osteoarthritis and less mnemonic for rheumatoid arthritis. So loss would be loss of joint space, common to both. You get osteophytes, subchondral sclerosis, and subchondral cysts. Subchondral cysts, as you can see there, is specific to osteoarthritis out of the two. Subluxation you would get in rheumatoid. Well, the last CND you'd get in rheumatoid. 5 is a skin, it's a bone cancer, which of course there are many different types. We don't have time to cover them in detail, but onion skin, remember onion skin is Ewing's. Kind of what I mentioned there. You can see the loss of joint space. If you follow the laser pointer, I don't know if you can see the laser pointer on recordings, to be fair. But osteophytes is there. I can't see any cysts on this. Subchondral sclerosis is thickening, so it's increased white space, thickening of the bone. Yeah, okay. So 19-year-old medical student, it's all of you guys. Probably a bit more than 19, but occupational health, latent TB, treatment for TB, infectious disease treatment, RIPE, if you guys know the mnemonic, performance later lethargy, lymphadenopathy, and a rash over the dorsum of her hands, positive antihistamine antibodies, and positive ANA. What's the likely cause? Which is isoniazid. So positive ANA, of course, you see that in SLE, but positive antihistamine antibodies, it's specific for drug-induced lupus. For the purpose of exam questions, you don't get DSD and DNA antibodies in drug-induced lupus. The most common causes of it are actually procainamide and hydralazine. The less common causes can include isoniazid, minocycline, phenytoin, HIMPP, if you guys want to remember that. And that concludes our presentation. Do let us know if you have any questions, and I shall put the feedback QR code again. When you watch these recordings back, do make sure you give us feedback. It would really help us out. And that concludes the presentation.